Hello, today we will talk about tumor lysis syndrome, an oncological emergency. Tumor lysis syndrome is a clinical entity caused by excessive release of intracellular metabolites into the bloodstream as a result of excessive destruction of tumor cells. Spontaneous or treatment-induced lysis can occur in rapidly proliferating tumor cells such as acute leukemias and high-grade lymphomas such as Burkitt's lymphomas. Normally, our cells contain purines and pyrimidines as DNA components, potassium as the main cation and phosphate as the main anion. As a result of excessive cell destruction, these metabolites are released into the bloodstream, which is responsible for various clinical manifestations. Hypoxanthine, formed as a result of catabolism of the released purines, is converted to xanthine by the enzyme xanthine oxidase. The xanthine formed is converted to uric acid by xanthine oxidase. Normally, at this stage, the enzyme uricase in all living organisms, from bacteria to mammals, converts the uric acid to allantoin, a more soluble substance, and removes it from the body. This enzyme is inactive in humans and some great apes. Because of the antioxidant properties of uric acid, the loss of the uricase enzyme could be seen as an evolutionary advantage for hominids. Nevertheless, high levels of uric acid cause some diseases such as hyperuricemia and gout. Excess uric acid can cause cryptocyle accumulation and precipitate in the renal tubules. This can lead to acute tubular necrosis and kidney injury. In addition, nausea, vomiting, diarrhea and muscle weakness due to hyperuricemia may be seen clinically. Increased phosphate levels in the blood can bind to calcium and decrease its level. Hypocalcemia develops due to this. Hypocalcemia can cause numbness, spasms, tetany, and even seizures. It may cause arrhythmias by prolonging the QT interval on ECG. Trousseau's sign and Chvostek's sign may be seen in severe hypocalcemia. Hyperkalemia can prolong the PR interval and sharpen the T waves on the ECG. Hyperkalemia is a serious condition and can cause life-threatening arrhythmias. Patient management. First, the risk is determined and intravenous hydration is started as prophylactic treatment and the patient is monitored. Treatment of electrolyte disturbances is important. In hyperkalemia, calcium gluconate is used to protect the heart. Insulin and dextrose are added to the treatment to return potassium to the cell. Hyperphosphatemia is treated with phosphate binders. The xanthine oxidase inhibitor allopurinol lowers blood uric acid levels in the treatment of hyperuricemia. Febuxostat, a potent non-purine selective xanthine oxidase inhibitor, is indicated for the treatment of hyperuricemia. It shows fewer hypersensitivity reactions than allopurinol and does not require dosage adjustment in patients with renal impairment. In more severe cases, rasburicase may be added to treatment to convert uric acid to the more soluble allantoin. It can then be easily excreted from the body. In severe or sudden electrolyte disturbances, dialysis is used.